All right, our next speaker is Michelle Springer. You've already seen her a few times, but she's a certified genetic counselor here at the University of Colorado and one of my colleagues. And she's going to be speaking today about genetic testing approaches in family.
Is it on? Is it on? Okay. My session, just to give you all a little heads up, is going to be a little bit different. I am going to talk for about 10 minutes. I get long-winded at times, so a little bit longer. Talk about genetic testing in families, the idea of cascade testing. What do we know about it? What are barriers? And then the second half of my session, I want to hear from you guys. We can read all of these things, but the best way for us to learn is to hear from you directly in terms of what your experiences have been. So on that note, I have no disclosures. The nice thing about having Dr. Lynch and Cami and everybody go before me is that this is review. Benefits of genetic testing. It can help us explain the underlying cause of cancer in a family. It can help us understand other cancer risks and what we should be doing for screening and prevention. Treatment implications. This is huge right now. We do genetic testing in many newly diagnosed individuals because we know it can impact their treatment options. And lastly, what I'm going to focus on, genetic testing is a hugely important tool to identify family members who might be at an increased risk. I think you guys have seen this like 10 times today. Dominantly inherited, both males and females can carry it. There's a 50-50 chance to pass it on. And if an individual does not pass it on, their offspring then cannot pass it on. So it does not skip generations. Just out of curiosity, how many people have heard of cascade testing, have heard that term? Okay, just a few. It is just our fancy way of saying testing in families where a mutation has been identified. It's a term that our field came up with a number of years ago, but really it is just the process of referring to a genetic counselor and doing testing in blood relatives of an individual who has tested positive. So we have a known mutation in the family, and now we think about testing all of those relatives. Generally, it is recommended that we do this in a sequential manner. And really what that means is we start with those closest individuals and then we work our way out. And really the premise behind this is that if, say, a sibling tests negative, their children are not at risk. It doesn't always happen. It's not always feasible, but that's kind of the preferred manner. And really the power of cascade testing, and you've heard this already, it helps us distinguish the carriers from the non-carriers. We identify the individuals who carry a mutation. We know that they're at an increased risk versus those individuals who test negative and we don't need to screen them. And Dr. Lynch talked about this morning in terms of, you know, before we had this, we were just screening all of those individuals. And then obviously for those individuals who do test positive, increased surveillance allows for early detection and even prevention. This information saves lives. What does cascade testing look like? This is how we think in the genetics world. This is a family tree. This individual with uterine cancer undergoes testing. She tests positive. We know that her siblings and her children are at a 50-50 chance. Her first daughter tests, she's negative. We don't need to test the children. Her other daughter tests, she's positive. Her son now, who is 17, is at a 50-50 chance. This would be the person I would then send to Cami, and she can have the discussion regarding, is testing right? Is it the right time? And then a sibling who tests positive, we know that their children are at a 50-50 chance. They undergo testing, so you guys kind of get the idea in terms of what that process looks like. The types of test results, and I included this because you're hearing a lot about how we are doing a lot of genetic testing using broader cancer panels. And that's partly why I include this. But one possible test result, they're positive. We know that they're at an increased risk. Increased screening is recommended, and their offspring are at a 50-50 chance. A negative test result, increased screening is not recommended based on the gene mutation. There's a big disclaimer with this that I will talk about in just a minute. But more importantly, for an individual who tests negative, their children are not at risk. This does not skip generations. A variant of uncertain significance, or a VUS, is something that we can possibly see if we are doing genetic testing beyond just that known familial mutation. So like Brian said, that C dot number, that specific variant that's in the family. And these are pretty common. Simply means there's a genetic change. We don't have enough data right now to know what it means. Our technology is ahead of us. These are common. It doesn't impact screening. We don't go out and test the whole family. The majority of them are ultimately found to be normal variation. Considerations, and we've already talked about some of these. Cami alluded to this, and I think it is so hugely important to remember. Family members who may delay testing or choose not to, it might not be the right time for them to test. They are still at risk and they still qualify for increased screening. This is something that a lot of families aren't familiar with. So if you have relatives who haven't tested, maybe they just don't want to know right now, they can still undergo increased screening. This is where that negative test result gets muddied a little bit. The presence of other non-Lynch related cancers in the family may warrant additional screening in those individuals who test positive or negative. And probably the best example of this is Lynch, or is breast cancer. We don't have any guidelines right now for breast cancer as part of Lynch syndrome. It's still very controversial. And what we know is that when we see that in a family, it will likely increase the risk to close relatives, and they may qualify for increased breast screening, whether or not they test positive or negative. So really important to kind of think about the cancers in the family, what's related to Lynch syndrome, and what's an outlier. And this ties in with another consideration, testing for a single gene versus a cancer panel. Like Dr. Lynch talked about this morning, what we know about technology is whether you test for one gene or a whole cancer panel, it's one and the same in terms of cost. So we need to think about, are there other cancers in the family that aren't related to Lynch, that are maybe, could there be another mutation in the family? What about the other side of the family history? An individual inherits 50% of their genetic material from mom and 50% from dad. So there's that other half that we need to think about. And this is really where genetic counseling and, you know, being able to really do a risk assessment is so important. This came up earlier, a hugely important consideration as well. How our genetic information is protected. It's protected by employers and our health insurers. They can't use it against us. There are loopholes. This is important for those individuals in the family who are thinking about doing testing. Get policies in place before you test. What do we know about cascade testing? Unfortunately, we're not doing as good as we could, is the bottom line. There have been many studies done looking at the uptake of testing in families. And what they uniformly show is that the rate of testing in at-risk relatives is less than about 30%. And this seems to hold true whether or not that information has been shared. So even in families where people are sharing this information, they're saying, hey, this is in the family, you guys are at risk. That rate of testing in at-risk relatives still seems to be low. And what we are finding is that there are barriers at multiple levels. And I've heard some of these concerns already in some of the discussions that we have, and we see them firsthand. There are patient and family level barriers in terms of financial, medical distrust, discomfort sharing information, the lack of awareness of risks and benefits, limited genetics knowledge. At the provider level, again, limited genetics knowledge. Time constraints. It seems like we all go into a doctor's office and they're looking at their watch and they're like, I have 10 minutes. What are your top 3 concerns? We need to do better. Lack of availability of genetic counseling support. We need more of us. Policies preventing direct contact of relatives. The same policies that help protect all of our genetic information, unfortunately, prevent us from reaching out to those relatives. And then barriers at the healthcare system level. When you see your doctor, they're focusing on your health, not your family's. Lack of availability of genetic counseling support. Costs related to screening. We've heard these concerns. They are very real. So what have we been doing as a genetics community to try and overcome these barriers? We are trying our hardest to come up with better resources. We hear you. We know that these barriers are out there. We're coming up with videos, patient family letters, chatbots, web-based tools, toolkits. A huge shout out to Connect My Variant for being here today. Brand new nonprofit organization. We need more resources like this. We need resources like Connect My Variant to help us have these conversations and increase the rate of cascade testing. So if any of you have not already been to the booth, please stop by Connect My Variant. Wonderful, wonderful resource. On that note, how are we doing for time? Oh, hey, I didn't ramble too long. My husband would have been proud of me. I would love to hear from you in terms of what have your experiences been? What has worked in your families to share this information? What are barriers? How can we do better? The best way for us to learn is to hear from all of you directly. Yes.
Thank you. First, I just wanted to say thank you for the infertility talk. I'm a former gestational carrier, carried a little guy about 8 years ago, and I've worked as a journey manager for an agency for about 8 years. So if anybody would like more information about that, I'd be happy to chat about that later. I think for my family, I have a 19-year-old, a 17-year-old, and a 13-year-old. My mom was diagnosed with cancer and then had the Lynch diagnosis. Then I was tested, was positive, and then did some proactive things like getting a hysterectomy. And as I start to think about my daughter, who's the oldest, and talking about testing, I think the biggest concern and barrier for us is, what does that look like for life insurance and things that they may need down the road that I'm afraid they can't get? And so I don't want to jump into testing without knowing what they aren't going to have access to. And to talk to your concern with the 10 years later, it isn't cheap for these kids to continue to manage their lives. And they're certainly not going to pay for some insurance plan that's expensive when they can't manage life financially anyway. And so I think that's a piece when we talk about the health insurance side, affording that's one side. But the other side is who's advocating for the life insurance and all of that side. That's something I just don't even understand, but I'd like to hear more conversations about that argument, and how we're protecting, yes, let's get everybody tested, but hold on a second. What are we risking by saying, yep, my name is, and now I have a red mark next to my name. So.
Is this on? So this is a very, very common question from a lot of people. In 2008, the GINA Act was passed. So it's the Genetic Information Non-Discrimination Act, and it's a national law that prevents discrimination against individuals with a genetic condition for health insurance, but it does not cover life or disability or long-term care insurance. There have been a few states here and there who have gone further and passed laws in their state where it does protect individuals for life insurance. But in most of the country right now, life insurance can use this medical information to determine how much a policy may cost for you. And so we always tell everyone to get a life insurance policy, no matter the age, before you get your genetic testing, especially if it's someone who is unaffected and has not had a cancer diagnosis. And I can give you our own personal example, because we did not do this when our oldest son got his genetic testing and he tested positive. So when our middle son was old enough to have his genetic testing, we went to our insurance agent and said, we need to get a policy for him before he gets his genetic testing, but we also want to try and get one for our older son so our oldest was 22 and Lynch positive, and our middle son was 18 and hadn't had genetic testing yet. And we went out and had to fight the insurance company. We got the exact same $1 million whole life policy for both of them, and it cost twice as much for our older son, who was and still is a pre-vivor and has never had cancer. And they didn't actually specifically ask. Now, this was 5 years ago, so things may have changed a bit, but they didn't specifically ask for any genetic testing results or any genetic diagnoses. But they do ask things like, has he had any diagnostic procedures? So you have to disclose that he's having annual colonoscopies or any other procedures that they may have. And then they dig in and they find that information out. So that's just kind of my real world example of, if you can do it, if your child is 18, gets a life insurance policy and then tests negative, you can make the decision to cancel that policy. But once they already have the testing, it's going to be a lot more expensive, even if they never have or get cancer. So that's
a great question, Dad. We definitely do hear that. Yes, Brian.
Well, I have two comments. One is that what we found is that the studies that say only 30% of people get family testing are really short-term studies. There hasn't ever been a study that just examined people for more than 2 years. And what we found in the families that we've interviewed is that this family communication is a process. It's not something that happens at one time. You get somebody who talks to their relatives, and then they talk to their other relatives, and somebody else tests positive, and they talk to each other. And so we're trying to get published a paper by a genetic counseling student who worked with us and interviewed a bunch of families and found that it was like a 4 to 6 year process, and maybe even longer for many families to do that family communication. And so in a year, maybe only 30% get tested, but that really should be really encouraging for everyone here. I've spoken with a few people who's already talking to who their brother won't get tested, to keep on bringing it up, talk about the Lynch Syndrome Symposium and what a wonderful time Dr. Patel has treated us to here. And just whatever opportunities you have, bring it up casually when you see them. And over time, people get testing, people see new things, people learn more about genetics, and it becomes easier. So that's the one point. The other point I want to comment on is that if the insurance companies knew what they were losing, they shouldn't discriminate. Because if someone's getting the prevention that we've all heard about today, their risk of cancer's as low or lower than the general population's risk of cancer. And so if they're charging more, this community needs to find the insurance company that won't charge more, and then that company is going to make a killing because they're going to be charging the same rates for people who have low risk of cancer. So that's something I feel like who are the advocacy groups that are doing legislation? So somebody needs to talk to the insurance companies and figure out which one everyone can go to that isn't charging more.
Thank you. Very good points, Brian.
Okay, I think we're gonna we'll take one more comment and then we're gonna move on.
More of a quick encouragement to all of you. My son had cancer in 2020, is in remission now. Because of the geneticist at Children's Hospital, we found out that we have MSH6 in our family. And because of her work, we're saving lives in our whole family. We had no idea that MSH6 even existed. So our family's just really grateful for geneticists and oncologists and immunologists who saved his life and are now saving other lives in our family because of this information. And he's going to be that kid who the life insurance is going to suck, and all of this is going to be pretty rough. But without any of this, he wouldn't have had a chance. And then without this, my sister and I maybe had things growing that were not healthy. And so now we can get those taken out and all of those different things. So we're just really, really grateful for the advocacy of the people that work in this, and the prevention of the genetic counseling has saved multiple lives in just our family. And we're so grateful for that.
I so appreciate that. I often will tell my patients when they talk about genetic testing, when someone is doing genetic testing, they are truly giving their family the gift of knowledge. They really are. This is information that is important for the entire family. And while we can't change the genes that we've inherited, we can potentially change the outcome of what those genes do. And that is why all of you are here today. Yes, we know that our family has Lynch syndrome, but by God, we are going to do everything that we can to prevent it. So thank you for sharing your story.